next speaker is Dr. Rohit Menon. Again, our audience, I think most of the audience knows Dr. Menon. He's our current emergency cardiology fellow and time to join us today. So Rohit graduated from Ohio State University's residency this past year, and also during that year served as chief resident. No fights between Susy and Rohit, Michigan versus Ohio State here, all right? He just recently completed ACEP's teaching fellowship, and Rohit has already been lecturing nationally, doing podcasts, and also lectured at last year's International Conference on Emergency Medicine, so I'm sure many people out there will be hearing his name quite a bit more. So thanks for joining us, and he's going to be spending some time talking about electrical storm. Great.
That's right. All right, is this the clicker that works, hopefully? All right, perfect. I don't have any financial disclosures. Maybe I should have posted my Venmo on this side as well. So we're gonna talk about electrical storm, ventricular tachydysrhythmias, and then review the medical management. I have a really exciting mnemonic to manage electrical storm for you. But first, we're going to talk about 3 rapid-fire cases. We're not going to have the answers to these cases until after the end, after we learn a little bit more about storm. So first, 35-year-old male witnessed arrest, polymorphic ventricular rhythm. Keeps arresting, keeps coding. They're en route to your facility. I want you to think of these 3 cases, what are the similarities, and then the differences in how you would manage the patient. Second, a 45-year-old female with non-ischemic cardiomyopathy, this time with an AICD. AICD keeps firing over and over and over. She says it's at least fired 4 times before she passes out again. Third, a 55-year-old vasculopath. Chest pain goes unresponsive. Polymorphic ventricular rhythm. They can't get them back. They do get intermittent conversion to sinus rhythm. They've tried amiodarone, they've tried lidocaine. In all of these patients, there is a storm occurring, and this is the mnemonic that we're going to learn today. It's sedation, treating the underlying cause, overdrive pacing, rhythm control, mechanical support, and sympathetic blockade. But first, what is electrical storm? Electrical storm is when you have a ventricular rhythm, either tachycardia or fibrillation, sustained VT, that's occurring at least 3 times, even despite after shock or anti-tachycardial pacing if they have an ICD. Who's at risk for ventricular rhythms and storm? First, myocardial ischemia, especially the inferior kind. Second, any patient with any structural heart disease or reduced LVEF. Additionally, male sex, Brugada syndrome, advanced age, and chronic renal disease as well. ICD patients are specifically a high-risk category. Amongst the studies in the late 90s and early 2000s, we have about 3 learning points from this. First, that there's around a 10 to 20% incidence in patients with ICDs to have electrical storm throughout their course. Second, these patients often are high risk for electrical storm within the first 21 months. And third, during that first 21 months, it's around a 4% chance that they have electrical storm. The scary thing about ICD patients is that they don't actually have a defined trigger all the time. Only around, in one study, 26% of patients ended up having triggers such as heart failure, acute MI, hypokalemia. In another study, 2004, only around 13% of those patients actually ended up having triggers as well. There are additional triggers not listed on this list that include fever, infection, sepsis, volume overload, psychological stressors as well. And the most common arrhythmia in ICD patients is actually ventricular tachycardia, monomorphic VT, far and away compared to ventricular fibrillation or polymorphic VT. So on to our storms mnemonic. We're going to go ahead and start with sedation first. So what is the utility of sedation in some patients with electrical storm? Sedation is listed as number 1 because I think it's one of the best and simplest options to actually control a storm. Oftentimes, these patients are having anxiety, they're having pain, so anything that includes anxiolysis, deep sedation if the storm is refractory, or just simple analgesia with pain control can often terminate a storm. There's a study in 2020, Bungard, who studied it's a small study, it's 15 patients, but they actually, after performing deep sedation with propofol, terminated around 80% of the patient's electrical storms. There's an additional study in 2020 that included 116 patients. They looked at multiple shocks that they had received in a 15-minute to 4-hour period just prior to the storm. And then they looked at the patients again after they had received deep sedation. And most of the patients, around half of them, had converted within just 15 minutes. So on to treating underlying cause. In order to actually understand the underlying cause, we need to understand the buckets of ventricular arrhythmias. Ones that I have are monomorphic VT, polymorphic VT, as well as ventricular fibrillation. To get started with monomorphic VT, what I want you guys to think of is structural heart disease, as well as usually a medical underlying cause. Oftentimes, these patients will have electrolyte abnormalities, such as hypokalemia or hypomagnesemia. Without thinking, usually I'll just order 2 grams of mag. We can check the levels and make sure that the magnesium is greater than 2, the potassium is greater than 4. And in these often medical patients, we want to also consider the volume overload, get some thyroid labs, infectious labs as well. Going on to polymorphic ventricular tachycardia, if it's a normal QTC, polymorphic VT, ischemia should be the #1 culprit. So call your cardiologist and try and get them to a cath lab. It gets a little bit trickier if you have a prolonged QTC. There's a lot of risk factors for a prolonged QTC or torsades. There's female sex, bradycardia, heart block, QT prolonging medications, hypokalemia, as well as a history of long QT syndrome as well. Oftentimes, we just try and address electrolytes in these patients, address thyroid studies, and then stop the QT prolonging medications. If this doesn't work, we're actually going to talk about our next step shortly. But first, ventricular fibrillation storm. This is deadly. Oftentimes, 85 to 97% mortality. Ischemia should also be a culprit for this. So, as a summary, monomorphic VT, think structural heart disease, as well as electrolytes, find an underlying cause. Polymorphic VT and VF oftentimes think about ischemia as the primary culprit. And if you do identify a prolonged QTC, then you can address their electrolytes as well. But what if the electrolytes don't work? This segues into our next point, overdrive pacing. So there are a couple indications to do overdrive pacing in electrical storm. One of which is a class 1 recommendation from the European Society of Cardiology in 2022. If you have a prolonged QTC, polymorphic ventricular rhythm, and you're not able to correct it despite precipitating conditions, then you could go ahead and then overdrive pace them. The concept of overdrive pacing is to raise the heart rate high enough such that you actually minimize the QTC. And in certain mechanisms, such as PVC-mediated electrical storm or polymorphic VT, you can actually, by reducing the heart rate, lower the amount of triggers of PVCs, causing an R on T phenomenon. You can also use overdrive pacing in slow VT, VT that has intermittent bradycardia and heart block, as well as patients who are having an acute STEMI and having electrical instability with that. Just as a quick refresher, it's best to float a TVP if you can instead of transcutaneous pacing. However, all the settings should be elevated. So the rate should be tachycardic, as we discussed. The output should be high, and then you can wean it down lower. And the sensitivity should also be high. High sensitivity basically means an asynchronous rate. On to our next part of our STORMS mnemonic, rhythm control. This is the meat and potatoes of the talk, but it's also the part of the talk that we don't have the most data for. The reasons why I have sedation, and treating the underlying cause, and overdrive pacing ahead of this is because those simple actions can sometimes terminate the rhythm within minutes. But something like amiodarone or lidocaine, that could take up to a day, maybe 2 days to actually work. We'll start talking about amiodarone first. Semhar gave an excellent talk on portions of antiarrhythmic medications. It's the everything mechanism. It blocks all the different kinds of receptors. It's safe in patients with decreased systolic function, and it does have some associated hypotension. However, most of that is actually because of the buffer solution. There was an original study in 1999, Kudenchek, that looked at 500 patients who were having refractory ventricular rhythms. And because they randomized 300 milligrams of amiodarone versus placebo, because the amiodarone group survived the hospitalization 44% compared to 34%, not that much of a difference, but still, that's why we use our dose of ACLS amiodarone as 300 milligrams. But before this study was done, amiodarone was actually used in electrical storm. There's 2 studies in 1995 and 1996 that I was able to find that studied around 350 patients and 275 patients that looked at amiodarone, and overall, it actually decreased the reoccurrence of ventricular rhythms after administration, at least in 40% of patients in the 96 study, and in a dose-related pattern. 1,000 milligrams of amiodarone sounds like a lot of boluses, but actually if you think about it, over 24 hours when you have a 6-hour 1 milligram per minute drip, and then a 0.5 milligram per minute drip over the remainder of 18 hours, that's actually a gram of amiodarone. Next, we'll talk about lidocaine. Lidocaine has extremely sparse data. It was thought that in ischemic conditions, lidocaine would help bind the receptors a little bit better. It's a sodium channel blocker. Don't know if that data is actually panned out. It's supposed to convert ventricular arrhythmias around 8 to 30% of the time. There was a recent retrospective cohort study with a large number of patients who have had VF and VT arrest, in-hospital arrest, performed in 2023. And amongst those patients, it actually showed that lidocaine, compared to amiodarone, potentially had better survival, better neurological outcome, quicker ROSC. So the data on lidocaine is still up in the air. I think there's more room to explore. One of the most interesting studies that I came across was the ALPS study. Compared amiodarone, lidocaine, and placebo in 3,000 patients randomized to around 1,000 each. The surprising part of this is that of the hospital survival to discharge, amiodarone, lidocaine, and the placebo actually had similar outcomes. It wasn't until they did a subgroup analysis of a witnessed out-of-hospital arrest, which was 66% of the patients, that they actually found a difference between the amiodarone and lidocaine compared to the placebo. So what does this mean? Well, it might mean that immediate response and just good quality CPR is better than anything that we can offer. But my take on it is that both of these drugs have a role in electrical storm, and oftentimes I'll just throw both medications on. Semhar did discuss procainamide. I do like it as a medication. I oftentimes use it for monomorphic storm because its active metabolite is actually a potassium channel blocker and can actually prolong the QTC. So you wouldn't want to use it in any polymorphic ventricular rhythms. There was a study that was done in 2017 that looked at procainamide versus amiodarone, and overall they found that procainamide had significantly less side effects in a 40-minute period. I love these studies that look at just 40 minutes or an hour or 2 hours, because it's a lot more realistic in our ED population, except with boarding, when you're not dealing with them for over the course of 1 to 2 days. Procainamide also almost converted twice the patients to a normal sinus rhythm as well. So on to mechanical support. Well, this isn't something that we do in the ED, but the reason why I have it is because we have to have it in the back of our heads. If someone's having an electrical storm or any sort of refractory ventricular arrhythmia, it's important to try and get that patient their mechanical support. ECMO has very sparse data, but there is one study in 2017 that had 26 patients. Around half of them had immediate conversion of their electrical storm as soon as they were placed on ECMO. The rest of them had a conversion of around 3 hours, which is still a reasonable time. By the time they're on ECMO, they're usually upstairs anyway. And this is to say that if your facility has ECMO capabilities or a cath lab, you can also reach out to your cardiologist to place additional mechanical support. In general, the mechanical support for balloon pumps and Impellas often benefit patients when the inotropic medications that are often used in arrest states of shock become harmful because they are pro-arrhythmogenic. All right, now we wrap up, and this is my favorite section of the talk because this is a little bit of evidence-based cowboyism as well. So what is sympathetic blockade? Well, sympathetic blockade can be anything from beta blockers to the very scary stellate ganglion block. There's a study of around 50 patients that got randomized to stellate ganglion block, sympathetic blockade, beta blockers, as well as just traditional ACLS. And of that group that got the sympathetic blockade, significantly higher survival and significantly better outcomes overall. You can see in just 1 week, 22% of deaths versus 88% of deaths. And overall survival, 67% in the sympathetic blockade group versus just 5%. So let's talk about beta blockers really quick. I think beta blockers are a pretty scary medication to use in any ventricular arrhythmia, mainly because we don't know if a patient's having decompensated heart failure. If you are using a beta blocker, it's better to use a non-selective one. The basis of this is this study that was performed in 60 patients that looked at propranolol versus metoprolol. The non-selective beta blocker, propranolol, had nearly 3-fold reduction in the incidence of ventricular arrhythmias, but again, this is over a 48-hour period. I have a little organized chart to look over beta blockers as well, because not everyone has IV propranolol or oral propranolol or esmolol. In general, if you have propranolol at your institution, based off of the study and based off of the data, I think that's the one to use for electrical storm, assuming no other contraindications. There are a few case reports on esmolol, and I do think this is actually a pretty good medication as well. The reason is because it's fast on, fast off. So you can try to put someone on an esmolol drip, and if they have some hemodynamic consequences, you can turn it off. But if they don't, and their ventricular arrhythmia burden decreases, then you might be able to add one of these other agents. It is a high volume, esmolol is a lot of fluid, so it's not a good long-term solution, but it may be able to get you an idea of whether someone can tolerate beta blockers. And then there's metoprolol. If you don't have any of the other medications, but you are confident that this is an electrical storm, there is data to support that metoprolol is better than nothing. Now for the juicy part of this talk, the left stellate ganglion block. So in 2017, there's a group that reviewed over 3,000 publications, 38 patients from 23 studies, and all of these patients were in electrical storm. They were all refractory to antiarrhythmic therapy, and around 80% of these patients survived to discharge with just an average of 10 cc's of bupivacaine. There was another study in 2021, Savastano et al., that this is a pilot study to another study that I will show you shortly. They showed 18 ganglion blocks in 11 patients, also 83% reduction in the amount of arrhythmias as well. So before I continue, all the residents in the room, please entertain me. Go ahead and take your right hand, raise your finger. Go ahead, take your left hand and pull your sternocleidomastoid muscle over. Pretend that you're about to do a crike and go lateral to it and then just poke that area. Well, you just did an anatomic anterior sphenopalatine ganglion block. And this is something that I would probably be too scared to do, but there are other options as well. The concept is that by pulling the sternocleidomastoid muscle over, you're actually moving the entire vascular bundle over, which is why you can stick the needle straight down into the vertebral body and inject your anesthetic. But if you're too scared to do that and maybe don't want to go get sued if something goes wrong, then there is an ultrasound approach where you can actually guide your needle to around where the carotid is and then inject anesthetic in that area. So why am I showing this? Well, a lot of centers may not be blessed with having all the resources that we have. They might need a transfer somewhere, and if you're really stuck, you've intubated the patient, you've given them their electrolytes, their Overdrive paste, you've done everything, you're trying to get them to another center, and you have nothing left, then this could be the Hail Mary that at least stabilizes the patient. There's a really cool video based off of Dr. Gupta on YouTube that'll actually show you how to do an anatomic ganglion block. So I encourage everyone to go watch that as well. Now, the last study that I want to showcase is the STAR study. It is also by Dr. Savastano. And this was actually performed and published in January 2024 and hit print March of this year as well. They looked at 19 centers over the course of 6 years. And their endpoint was, can we teach people how to do a ganglion block to the point that we can reduce the arrhythmia burden by at least 50%? And the best part is the operators didn't just include cardiologists, didn't just include intensivists, but it also included emergency physicians. So around nearly 200 of these procedures were performed in 130 patients. So let's look at this really closely. Surprisingly, although many of you would never want to do an anatomical ganglion block, over 100 of these were anatomical. And they used bolus and bolusing infusion of anesthetic as well. This is the anesthetics that they used. By and far, the largest, most common anesthetic, just lidocaine. So how many complications do you think happened with this study? Actually, before that, these patients, this is the most interesting part actually. Before the intervention, only around 20% of the patients were intubated or had any kind of deep sedation. Most of the patients did have amiodarone or lidocaine. So now, how many complications do you think this study had? Just one major complication of respiratory depression, as well as 2 complications of bradycardia and hypotension. The respiratory depression complication was in someone who was not intubated as well. They did 12 hours before the ganglion block, 12 hours after. This is the inner quartile range of the amount of shocks or ATP events that were going on, anti-tachycardial pacing, so patients with ICDs, and median of around 6, 12 hours before the block, going down to 0. And then 1 hour before the procedure, around 2 events, the hour preceding, 0, the hour after. So the stellate ganglion block significantly reduced the arrhythmia burden, oftentimes to 0. And interestingly enough, no significant differences between the bolus and the bolus infusion method. No significant differences between the anatomic and the ultrasound approach. And it was looked at in both centers that had low and high volume and had similar efficacy. So if you're in a pinch and you don't know what to do and you're all on your own and you just need to get the patient stabilized to the point that you can move them to their next location, move them to final destination therapy, transplant, etc., it's a good Hail Mary to at least know about. So let's conclude our cases. So the first case that we had was this polymorphic rhythm that appeared like torsades. We talked about pain control, we talked about addressing the electrolytes, we talked about overdrive pacing as well as lidocaine. And eventually, if none of this works, you can get this patient mechanical support or try blockade. Similarly, the AICD patient who has non-ischemic cardiomyopathy, you do want to discuss this patient oftentimes with cardiology. However, similar concept, sedation, underlying causes, amiodarone, lidocaine, mechanical support, potentially even beta blockade, or procainamide since this is a monomorphic VT rhythm. And for the patient that is 55 years old, vasculopath, having chest pain, same story, but this time try and get them to a cath lab. So let's do our key takeaways. Electrical storm is a devastating condition with very high mortality. Understanding the different types of etiologies of ventricular arrhythmias will help you guide your treatment. And when in doubt, remember your storm's mnemonic. Early sedation, treat the underlying cause, consider overdrive pacing, rhythm control with amiodarone and lidocaine most commonly, as well as consider any mechanical support or sympathetic blockade. Thank you so much for your time. I appreciate it.
All right. Well, once again, we have a few minutes for questions. Coming in through the chat, Dr. Miller?
Yes, there are a couple questions about your opinion and practice pattern for utilization of double sequence or dual sequence defibrillation for patients with electrical storm.
Yeah, so this is more of a nuanced point, but I think it's great. I've used it at least in one patient. Electrical storm is slightly different than refractory ventricular tachycardia, and oftentimes I think of double sequential defibrillation as to be used in refractory rhythms. Refractory VT or ventricular arrhythmias are when the patient remains in the arrhythmia, you shock, you give amiodarone or lidocaine, they continue remaining in that arrhythmia. Electrical storm is when you actually have a little bit more of a break. So I do think that double sequential defibrillation is overall good if you have access to the equipment, but there is a slight difference between just getting someone out of incessant VT versus managing electrical storm.
Thank you. And there was another question about the sedation recommendation. And is this like a brief period of sedation that produces sustained termination, or is this sedation in like, I guess, in a course of like prolonged sedation and airway control?
Yeah, this
Sorry
is
about that. Stumbling over that one.
maybe really bad, but this is a sedation until it's a not my problem in the ED approach. Most of the studies use propofol, and you can actually use dexetomidate as well as ketamine as options as well. However, oftentimes what they find is when you wean the sedation, the arrhythmias sometimes come back. So at least for our purposes in the ED, you try and keep the patient as sedated as possible until they can get some of that additional mechanical support or sympathetic blockade, or they can be put on a drip that can then be weaned as well.
I got one question sent to me regarding electrical storm in somebody who has an AICD. They come in being shocked repeatedly. When those patients come in, do you just them continue being shocked, or do you turn off the pacer or the defibrillator and then start shocking them yourself?
Yeah, that's a really good question. So there's 3 types of multiple shocks that a patient with an AIC can come in with. There's a concept called phantom shocks, where they're actually not being shocked, they just have the sensation of the shock, and that's supportive care. Then there's inappropriate shocks, which are often due to non-arrhythmogenic causes. So you can identify that with a quick ECG or put them on telemetry and see if they're inappropriately being shocked. If they're inappropriately being shocked, then you absolutely want to place a magnet on them. And oftentimes, if you do put a magnet on them, just in case, I would have pads placed on them as well. The case with the appropriate shocks is a little bit trickier, because if you put a magnet on that patient, they actually might code. And in those cases, I would, until you have all your equipment in the room, actually give them sedation, analgesia, and continue letting the AIC do its work until you have pads on and you're able to intubate, secure their airway, and then sedate them, and then follow the rest of the algorithm. It's a good question.
All right. Well, thank you very much. We'll have more questions for you at the panel, no doubt.
Thank you.